Welcome to part 3 of respiratory. This section is going to focus on upper airway disorders like the common cold, COVID, and influenza. The upper airway disorders are called upper respiratory infections, or URIs, and these consist of colds like the common cold or viral rhinitis, influenza, and COVID. URIs are the most common cause of illness and affect most people at some point. The average adult is going to get 2 to 4 URIs each year. Some URIs can be acute, lasting several days, while others can be chronic and they can last weeks or months. Viruses are the most common cause of URIs, but bacteria can cause them as well, like with sinusitis. URIs affect the nose, sinuses, pharynx, larynx, and upper trachea. The common cold is technically called viral rhinitis, and it's characterized by inflammation and irritation of the mucous membranes of the nose. Rhinovirus is incredibly common and highly contagious, affecting over 1 billion people each year. It's usually self-limited, meaning it's going to treat itself. It's most prevalent in the early fall and spring with those seasonal changes, and this virus loves low humidity conditions like cold weather. It's not caused by exposure to cold temperature or by being exposed to rain. Rhinovirus is so contagious because humans shed the virus for about 2 days before any symptoms appear, so we don't even know we're sick when we're contagious. And rhinovirus has many symptoms, but not every symptom is going to be present in every person. Some people may have a low-grade fever, nasal congestion, discharge, sneezing, watery eyes, sore throat, chills, headache, muscle aches, and possibly a cough. And I bet this sounds familiar to most of you because most of us get this a couple times a year. Influenza and COVID are 2 other common viruses that make us sick. They have many similarities, but they are caused by different viruses. Influenza is caused by either the influenza A or influenza B virus, and COVID is caused by the SARS-CoV-2 virus. Both viruses are contagious, with COVID being more contagious than influenza because it takes longer for COVID symptoms to start. Influenza symptoms start about 1 to 4 days after infection, while COVID can take 2 to 14 days. Both of these have the potential to cause serious illness in people, although people usually have mild to moderate illnesses. Both viruses have almost the exact same symptoms, so it can be hard to tell the 2 apart without testing. Both can have a fever and chills, nasal congestion and discharge, sore throat, headache, muscle aches, cough, shortness of breath, and even nausea and vomiting. COVID can also affect taste and smell even after the illness has resolved. Influenza doesn't normally affect taste and smell. Complications are where a lot of these similarities end. Most people will recover from influenza on their own in a couple of days to a week or maybe 2 weeks. Some people may require hospitalization, but those people are typically very old or very young and they might be immunocompromised. Secondary infections like pneumonia are common with influenza, and that's usually what causes the hospitalization with influenza. Influenza can cause respiratory failure, sepsis, cardiac injury, and inflammation of the heart, but not at the same rate as COVID. COVID, however, can last for weeks or months, and more people require medical treatment and intervention from COVID than influenza. COVID rates of severe complications like respiratory failure, sepsis, secondary infection, and inflammation is much higher than influenza. And COVID also has a complication of blood clots and multi-system inflammation that can cause multi-system failure. These complications can happen even if the COVID illness was mild. Both of these viruses have vaccinations to help prevent or limit the severity of the illness. However, because both of these viruses mutate quickly, the vaccines aren't completely effective in all people, which is different than many of our other viruses we vaccinate against. Assessing our patients for upper respiratory infections are really asking about their health history, their exposure to sick people, and asking about their symptoms. Sometimes URIs can present like allergies, or allergies can present like URIs, so we do need to ask them about any allergies that they know they have. A visual inspection of the nose and throat will show redness and drainage, and palpation of the neck may reveal swollen lymph nodes. We can do a nasal swab to check for influenza and COVID, but rhinovirus usually doesn't get a swab. And honestly, most people who have rhinovirus, they're not sick enough to go in to get any treatment, so we wouldn't be swabbing them anyway. Managing URIs is usually about symptom management. We're going to encourage oral fluids, rest, and over-the-counter medications to help alleviate the symptoms. These medications can include NSAIDs like ibuprofen for pain and inflammation relief, as well as fever reduction. Acetaminophen can also be used for fever and pain relief. Antihistamines like diphenhydramine or Benadryl may help the nasal decongestion and discharge symptoms, as well as sneezing and watery eyes. Antihistamines have a major side effect of drowsiness, so they really need to be used with caution during the day. The data shows antihistamines are not very effective for the common cold, but the combination of antihistamines and decongestants together may have better effectiveness. Decongestants like pseudoephedrine or Sudafed help to reduce swelling in the nasal passages, which relieves the pressure and pain while improving airflow. They come in oral and spray form and have the side effect of keeping you awake, so they're best used during the day. The nasal sprays like neosynephrine or Afrin, they don't have as much as this effect as the oral tablets do. Decongestants can raise blood pressure, so they really need to be used in caution with people with hypertension. And there's some new current data out there that's showing decongestants don't work at all. We actually also have expectorants like guaifenesin or Mucinex and Robitussin that help to loosen up the mucus and secretions so they can be coughed out or blown out of the nose. And there are also many combinations of cold medications like Dayquil and NyQuil that use a bunch of combinations of all of these drugs together in one dose, and they do seem to have better effectiveness together in one pill than using these medications on their own. A lot of what nurses do to treat URIs is related to symptom management. We can elevate the head of the bed to relieve sinus pain and congestion. We can offer hot packs for the face and head to help with congestion. We administer ordered analgesics, antihistamines, decongestants, and expectorants. We monitor for complications, especially with COVID and influenza. We can offer warm saltwater gargles for a sore throat, and we encourage oral fluids to help with secretions. We also want to encourage rest, because secondary infections can occur if the body gets too run down, and we really want to prevent secondary infections. And if our patient does get a secondary infection like pneumonia, we're going to treat that as well. Because most URIs don't end up in healthcare, the majority of what nurses do is really going to be educating on preventing the URI in the first place. This can be by avoiding people who are sick, educating on the need for frequent hand washing, using tissues, and then safe sneezing, which is sneezing into the upper arm or elbow instead of sneezing all over the place. We may also need to educate on how the virus is transmitted to prevent the spread to other people, like our people who live in our house with us. We can also educate when to contact their healthcare provider or go to urgent care. If a secondary infection is present, we need to educate that person on the need to fully complete antibiotics if they're prescribed antibiotics. We also need to educate on the importance of annual immunizations if the person is at high risk, if they're elderly, if they're in school, or if they work in a high-risk location like in healthcare. And this is the end of part 3.